last year to do a simulation workshop, and also very thankful from our colleague from King Faisal Specialist Hospital, that 7 experts, senior in the critical care, neurology, hormonal therapy, endocrinologists were involved in this workshop. Dr. Faisal Shaheen, the General Director of SCOT, was not able to join us today as for previous commitment in the International Congress outside the country, but he will be here tomorrow to present an overview about the international practice of donation and how it's going, the organizational aspect in Saudi Arabia. So let's start with this interactive question, and as mentioned by Dr. Riyaz, the idea is not to test your knowledge, just to explore the various ways from the audience about some ethical issue about the donation and transplantation and dealing with the potential donor in the ICU. So I believe everyone received the pad. It is activated. Just you press, once you see the pooling is open green, and you see here the time bar appear, time clock, just to press the right answer for you. And just to start with the test, what is the capital of Saudi Arabia? Is it Dammam, number 1, or Jeddah, number 2, or Riyadh, number 3? Just you press now. You have 15 seconds to answer this question. And we'll see the number of responses. Should have around 40. Okay, it's 95% Riyadh. I'm sure some visitors from Jeddah, Eastern, would like to have the capital, the city. Okay. So the first question is, brain death declaration depends on heart and lung cessation, or brain circulation cessation, or soul departure, or should be 1 and 2, heart and lung with brain circulation cessation. You press now. Criteria for brain death declaration. Or death declaration by brain function criteria. Okay, very nice. So 68% believe it is the right answer, brain circulation cessation. Still some believe that should be associated with the circulation and the brain. Who performed the diagnosis of brain death? This is based on the national protocol. We are not talking about United States protocol or UK protocol. Here in the country, who performed the diagnosis of brain death? Any trained physician except the transplant surgeon or transplant physicians, or the ICU nurse or transplant surgeon, or only by intensivist, neurologist, and neurosurgeon? Okay, this is where we are, Dr. Qawi. I'm sure he will explain about the death declaration in the country. Of course, we feel more comfortable if only we give this task to intensivist, neurologist, and neurosurgeon. But according to the national protocol, that any trained physician may apply the death declaration. Also, according to the national protocol, as precondition for diagnosing brain death, the body temperature should be below 34 degrees centigrade, or equal above 34 degrees centigrade, or above 36.5 degrees centigrade. You know, there are variations by different national protocols. So here in the country, as precondition, Okay, 50-50 between 34 and 36. Interesting. The latest national protocol that asks to apply the clinical examination should have above equal 34 degrees centigrade. Also, we have a precondition to perform the apnea test, and according to our national protocol, it should be above 32 degrees centigrade, or equal above 34 degrees centigrade, or 36.5 degrees centigrade. Okay, still also 50-50 between 34 and 36.5. This one was adopted by the National Committee that we are honored that the chairman of this committee is here today, because Saudi Arabia is one of the most rigid countries applying the death declaration by brain function criteria. So they stress that for apnea test, the temperature should be equal to 6.5 degrees centigrade. The apnea test should be done as a first test, or it is an optional, or it is last test to be performed, or should be done twice. Very good. So the majority gave that 79%, 85 answer. It is last test to be performed. This is a very sensitive issue, switching off the ventilator after brain death declaration. In your opinion, should never be done, or it is upon doctor's decision, or it is a family matter, or there is fatwa to be considered, or 2 and 4, between upon doctor decision based on the fatwa to switch off the ventilator. Okay, 45%. Interesting that family matter. Okay, this is only 3%. There is fatwa 18, should never be done, 20%. Okay. Brain death declaration of a deceased donor should be signed after organ recovery. So after removing the organ from the dead body, yes or no? Okay, should be done before the harvesting. No, any transplant surgeon would accept to start any recovery process before to assure that the patient, our donor, is declared death according to the solid and rigid protocol. When brain death occurs, the blood circulation to the brain continues, yes or no?
This is not working, I think.
Not working?
I think so.
Of course, no. So we should prove that there is no more circulation to the brain in this declaration by brain function criteria. Previous cardiac arrest in a potential donor makes him an unsuitable donor. I mean, during the stay in the ICU, we have death by brain function criteria and cardiac arrest has happened. Unsuitable or no?
Thank you.
Okay, very good. The majority then 87% no. Still, we have to be considered as a potential donor, and resuscitation should be done full CPR as any other patient in the ICU, keeping in mind the option for donation discussed already with the family or not. This is about management. After assurance of adequate volume resuscitation, the first line vasoactive agent to be used in following brain death in the potential donor is dobutamine, norepinephrine, epinephrine, dopamine, or phenylephrine. What is the first line vasoactive agent? Okay, still interesting. So Dr. Riyaz will have a very nice lecture about the monitoring support in brain death donor. Other question also for management. The 35 years old male who was diagnosed with brain death after motor vehicle accident, and discussion for potential organ donation has been initiated with the family. The patient developed hypotension that did not respond to volume resuscitation and has been initiated on a vasoactive agent. An echocardiogram was done and revealed an estimated ejection fraction of 40%. In addition to septic workup and empiric IV antibiotics, what is the next most appropriate setup to initiate is further volume resuscitation or dobutamine infusion, intravenous levothyroxine, or consult cardiology, or continue observation. So we have hypotension not responding to volume resuscitation, and we apply vasoactive agent in this one. Also we apply empiric antibiotics. Well, what is the most appropriate step? Okay, 46% give the dobutamine. I believe Dr. Hussein Raif will give also a very nice lecture about the hormonal therapy and the potential death in the ICU. After completing an apnea test as a step to confirm the diagnosis of a brain death in a patient with massive subdural hematoma, the patient oxygen requirement has increased from 45% to 80%, while he was maintained on a PEEP of 10. The most appropriate intervention is to increase the PEEP to 12, or do a single recruitment maneuver, to administer bronchodilator and observe, or to administer one dose of Lasix and reassess, or to maintain protective lung strategy. Patient with the oxygen requirement increased from 45 to 80, and PEEP of 10. Okay, so do single recruitment maneuver 22% and maintain protective lung strategy the majority. Also, our colleague Dr. Hassan Hawa is going to tackle this subject about the respiratory maintenance, and we have wonderful workshop tomorrow about the use of ventilator in the maintaining the potential donor in the ICU. A 59 years old female with an ideal body weight of 60 kg who was diagnosed with brain death because of severe vasospasm due to subarachnoid hemorrhage. The patient is ventilated with pressure regulated volume control mode of ventilation with PEEP of 8 and FiO2 of 45%, tidal volume of 580 and a rate of 16. Her chest X-ray shows bibasilar atelectic changes, and blood gases reveal of pH 7.46, PCO2 33, and PO2 125. The most appropriate change on the ventilator to is maintain the same ventilator, increase PEEP to 10 and titrate the FiO2 down, or decrease tidal volume to 400 and maintain the same level, or decrease tidal volume to 400 and decrease PEEP to 10, or change the mode to pressure control ventilation and monitor. Okay. Also very interesting. Okay, the majority gave that decrease tidal volume to 400, maintain the same level, increase PEEP to 10 and titrate FI down to 24%. That the right answer is to decrease tidal volume to 400, is 580, and increase PEEP to 10 instead of 8. And also this subject will be tackled by Dr. Hawa in today in his lecture. All the following is correct in the management of brain death potential donors, except hypernatremia is highly significant risk factor for post-liver transplant mortality. Bronchoscopy is indicated on all brain death potential organ donors. Intensive late management of brain death donor is associated with an increase in organ recovery for transplantation. Or norepinephrine is the preferred vasoactive medication in brain death donor. We have one exception. Okay. Mostly goes for 67% bronchoscopy is indicated in all brain deaths, and norepinephrine, the exception is the norepinephrine is not the first line choice as vasoactive agent. Combined hormonal therapy in support of brain death donor may include the following agent, except methylprednisolone, levothyroxine, insulin, growth hormone, or arginine vasopressin. The only exception when we apply a combined hormonal therapy. Very good. Growth hormone is the 64%. A 50 years old male who gets involved in motor vehicle accident, his initial examination showed no opening to his eyes, no verbal response, and rigid extensor response with decerebrate posture. Vital signs were stable. His Glasgow Coma scale is 6, 5, 4, or 3. No opening eyes, no verbal response, and decerebrated. Okay, 56% is the majority. The Glasgow Coma scale here in this scenario is 4. No eye opening 1, no verbal 1, and decerebrate 2. Glasgow Coma scale is 4. 60 years old man brought to the hospital after he was found at home unconscious. Patient was intubated, sedated, and paralyzed en route to the hospital. CT head showed massive intracerebral bleeding, and the next day you asked the nurse to stop all sedation and paralytic. All laboratory tests, including electrolytes, were within normal limits. His Glasgow Coma scale was 3, and core body temperature is 37. Your nurse asked you if you want to perform brain death exam, and your answer was, yes, we can perform the test since the Glasgow Coma scale is 3 and his lab and vital are and temperature within normal limits, or no, we must wait until we perform 2 other ancillary tests. Or no, we must wait at least 24 hours after stopping all sedative and paralytic before we perform apneic test. Or yes, we can perform the tests, but after we screen him for cancer. This is again about inclusion and exclusion criteria to apply the clinical examination. Very good. Okay, so we must wait at least 24 hours, and I'm sure Dr. Artawi will cover this issue in his lecture. Human life can't be maintained in the absence of kidneys, liver, heart, brain, or lungs. Okay, 56 brain, still kidneys 19, I don't know who is, okay. Heart 22%. The most relevant medical evidence in death declaration, is it irreversible complete loss of the ability of consciousness and awareness, or irreversible complete loss of the ability to breathe, or irreversible complete loss of the heart beating, or should have 1 and 2, consciousness and breathing, or 1 and 3, consciousness and heart beating. The most relevant medical evidence in death declaration. Okay, 1 and 2 is 47%, very interesting. Okay, so split between 22, 47, and 19. Deceased organ donation in Saudi Arabia agreed upon by previously signed donor card, or consent from next of kin, or family consent is not mandatory, or not allowed in the country. Okay, consent 77, previously signed. Not very good. So here we apply the opting-in system. There are variations worldwide. Some countries apply the opting-in system that next of kin is mandatory to have approved the donation. Other countries practice the opting-out system that every citizen considered as a donor unless they approve is objecting during his life the donation. So the best way to express your wish for organ donation after death is to hold a signed donor card, or to inform your family about your wish to donate, or to get medical report from your treating physician, or 1 and 2, to hold a signed donor card and to inform your family about your wish to donate. Okay, very good. So the best way to express your wish is to discuss this issue with your family and to hold a signed donor card in support of this national program. The last one is, what is your position towards organ donation? Are you objecting for religious reason, or are you objecting for social reason, or accepting it, or still need more information? Okay, 83%. Only 10% objecting for religious reason. I hope that 7% just need more information. And I hope you will get answer for your query during this 2 days workshop. Thank you very much. you.